Dear colleagues, thank you very much for the laudation. Well, Professor Hegyi set the bar pretty high, and I'll not only be the first presenter today, but it's also pretty a tough job to perform after receiving this prize, but I will try to do my best. So today you are going to get some insight to my PhD topic, which is about predictive and prognostic biomarkers in urooncology. And let me tell you my vision, which is that I strongly believe that the development of precision medicine and individual molecular targeted therapy will contribute to the life expectancy and life quality of oncologic patients in the future. And according to this vision, my mission is to find biomarkers which can guide optimal therapy sequencing in prostate and bladder cancers. Well, in line with this vision and missions, let me show you my two specific projects, which are pretty much related to one another. In both of them, we are assessing BRCA-positive metastatic castration-resistant prostate cancer patients. So let's move on with the first project, in which we are focusing on the first-line treatment options. We have just finished drafting our paper, and we would like to send it to the number one urology journal, the European Urology Oncology, and I'm pretty happy to announce that we have already participated in many conferences, both in Hungary and abroad as well, and we have taken 3 out of 7 prizes on the Central European Urology meeting in Vienna with my colleagues who are sitting here. So let's move on. Why should we talk about prostate cancer? Because this is the most common type of solid tumors of men. 1 out of 8 men will develop it sometime during their lifetime, and 10% of the advanced cases are the so-called BRCA mutation positive ones. Well, probably you must have heard about the BRCA mutation, because that was the one because of which Angelina Jolie underwent a prophylactic mastectomy, ovarectomy, and adnexectomy. Her mother and grandmother suffered in breast cancer. But why is it important for us in urology? Because the BRCA-positive prostate cancers represent a much more aggressive disease entity. These patients' survival is 50% worse compared to the wild-type ones. And beside the different biologic behavior, these patients represent a different clinical entity or clinical entity as well. We have an on-target therapy for BRCA mutants, the so-called PARP inhibitors, but you can only give them from the second treatment line. And the question of which first-line available treatment is the most suitable for these patients has not been answered yet. So our aim was to assess the therapeutic response to these treatments in this novel molecularly selected subgroup of patients. Well, this kind of aim and setup would cry for an interventional study design, but during our preliminary search, we haven't found any studies which would have directly compared this agent to another. So we decided on performing a proportional meta-analysis where we are assessing the PSA 50 response rates. PSA 50 is defined as a decrease from baseline PSA at least 50%. And for this purpose, we were using the COCOPOP framework. Our second question was, and our second goal was to assess the progression-free survival in these patients. And fortunately, we could use individual patient data from many articles, and we could compare abiraterone, enzalutamide, and docetaxel to one another using a random effect Cox regression method. We have performed our systematic search last October, and from the 11,000 hits, we ended up with 15 full-text eligible articles. And now let's talk about our results. First of all, PSA 50, regardless of treatment line. We could include more than 200 patients in this analysis. In case of abiraterone, 53% responded. For enzalutamide, 56% of the patients responded, and in the case of docetaxel, this response rate was 47%. Now let's see what happens when we are just focusing on the first-line treatments. We could assess almost 100 patients, and in the case of abiraterone, 52%, for enzalutamide, 64%, and for docetaxel, 55% responded. Now let's talk about the progression-free survival. On all these survival curves from the different studies, you can see with the dotted line the enzalutamide-treated patient and the continuous line the abiraterone-treated patient's survival. And there is a trend towards a better survival in case of enzalutamide. And a random effect Cox regression model showed a statistically significant benefit, which was a 53% lower risk for progression for the enzalutamide-treated patients. So to sum up things, first of all, I would like to talk about our strengths and highlight that this is the first meta-analysis in this topic, providing a comprehensive overview about PSA 50 and progression-free survival in this novel subgroup of patients. And we could use individual patient data with the baseline characteristics. Obviously, we have got some pitfalls as well. First of all, the small sample size, and there are no studies comparing directly the agents to another. Therefore, our methodology was a bit special, let's say, and this is a limitation of this. And the progression-free survival, the definition of progression-free survival differed slightly between the studies, so we used a composite outcome. And we also have to note that the BRCA mutation test methods may differ. Both the indications and the population, the sampling of the population may have differed about these studies. Well, what can we conclude from all these? First of all standard therapies. In case of all standard therapies, we have seen a response in BRCA-positive patients, but for enzalutamide treatment, we saw the highest PSA 50 rates, and it performed better than abiraterone in terms of progression-free survival. But what can we take from all of this for our daily practice? Well, we can only take that these patients respond to all first-line treatments. However, then can be differences between the agents. But we would also like to highlight the importance of performing molecular marker-driven interventional trials to compare these agents and to provide a higher level of evidence in this topic. Now let's move on to the second project, in which we are focusing on the later therapeutic options in the same population. And to what I have talked to you about previously, I would like to add that the 5-year survival of metastatic castration-resistant prostate cancer is only about 30%, despite the fact that we can choose among 7 different agents. So it would be really important to find the optimal sequencing of these agents. And our aim for this study was to assess the therapeutic response for the later line treatment options. And we have, for this purpose, we are using the same framework and the same kind of methodological approach. And we have done the selection and the systematic search and the selection. We started about around 6,000 articles and ended up with 23 articles. And currently, we are about halfway of the data extraction. As an overview, you have you have heard about 2 projects today. In both of them, we are assessing the BRCA-positive MCRPC patients. And we would like to submit both papers in this summer. And as closing remarks, I would like to tell you the words of Saint Francis of Assisi, that first you should start by doing what is necessary, then what is possible, and suddenly you are doing the impossible. Thank you for your attention.
I would have a question about, you have said the BRCA mutation tests differed. How did they differ? And if I understood it correctly, there were germline mutations and somatic mutations as well included. Could it affect the result at all? And then I would have further questions as well.
Thank you for this great question. In this analysis, we have included both germline and somatic mutations, but the only inclusion criteria was that they have to be pathogenic mutations. And we have performed subgroup analysis regarding where in those cases when we had the individual patient data and try to distinguish or try to assess the impact of germline or somatic mutations. But due to the, as you could see, the low patient numbers, we couldn't detect any differences. But yes, the first part of your question was about the different test methods. It's really important that we included every studies we could, because there is a real lack of information about this topic in the literature. So there were studies which performed primary biopsy from the prostate and they assessed the tumor tissue, but there were other studies which were using liquid biopsy methodology, which sometimes can underestimate the level of the frequency of a mutation. Of course, it's not that sensitive and specific compared to tumor sampling from primary tissue, but it's where these studies were in which they used these methods were really high quality interventional studies. So, but this is still a question and a limitation.
My second question with regard to, I do not know anything about the PARP inhibitor treatment of prostate cancer, but in other cancers like ovarian cancer, if you have not only BRCA mutation, but any homolog repair deficiency, that could as well be potential of PARP inhibition therapy. Is there any information about homolog repair deficiency other than BRCA mutation in prostate cancer? And did they examine it in these studies?
Thank you. This is a great question again. Well, in case of prostate cancer, it may differ among countries. So there are different approaches. The first study based on which the olaparib got an approval was the PROfound study, and they in their interventional cohorts, there were a mixed group of HRR homolog repair deficiency patients. And therefore, the FDA approved PARP inhibitors for all, for 12 kind of deficient types. And, but in contrast to this, the EMA, the European Medical Agency, only approved it for the BRCA mutants, because in a post hoc subgroup analysis of the study, olaparib showed the best effect for specifically the BRCA mutant patients. So this is the difference between the regulations of the European Union and the FDA. But I have to add that the guideline of the European Urological Guideline still recommends, or still recommends giving PARP inhibitors to any homolog recombination deficient patients.